Hello, thank you for joining me on this new presentation about properly establishing medical necessity. This isn't an easy subject to discuss because it varies from patient to patient, and then there are so many healthcare organizations that require so many different rules, and there are many different doctors and many different specialties. So I'm going to try to give you a general picture, but trying to focus in on the things that are the most important. Medicare, and that's probably the one that we want to use as a standard. Medicare defines medical necessity as healthcare services or supplies needed to prevent, diagnose, or treat an illness, injury, condition, disease, or its symptoms, and that meets accepted standards of medicine. That's what it says. Experienced coders, for instance, and they're well known about that, they're all very well aware how to use the right diagnosis codes to report the service provided and inform the payer that it was medically necessary. But these services must be, first, in accordance with a generally accepted standard of practice. Second, clinically appropriate terms that have to be used of the type, of the frequency, the extent, the site, and the duration. I mean, this is just the way it works. These things have to be in there. Frequency means how often. The extent is to what extent was that done. The site, where. And the duration. Was that short time? 2 minutes, 5 minutes, 12 minutes? Here's another third consideration, and that is effectively for the patient's condition or the injury to be reported appropriately. Reporting the right ICD-10 and CPT codes, which supports the medical necessity for the procedure. This tells the payer why the service was performed. Why? The documentation must include the diagnosis for all the procedures that are performed, as well as the diagnosis for each diagnostic test that is ordered. You know, it's interesting. There was a report published by the American Association of Professional Coders, AAPC. You may have heard of it, which reminds physicians that establishing medical necessity is important for even low-level evaluation and management code, the 99201, 99211, the ones that are so low. These visits, which are typically outpatient visits, in such cases, the presenting problem may be minimal, if anything at all. Some people might even say negligible, but it's still something. So outpatient visits essentially includes three components. One is documentation that supports the level of service billed. Two, it's important, is to note that those notes themselves that you have written, they must contain all the elements required to support the level of service that you selected. Last but not least, establish medical necessity, and that is, and it should be established clearly, it should be a reason, a clear reason for the visit, and how the assessment and the plan are related to the reason for the visit. Those are things that you have to pay attention to. Now, there are ways to do certain things. For instance, to prevent under-documenting, the documentation must portray all the elements of history, exam, medical decision-making, and all this to indicate the level of service for the encounter with the patient, even though these are outpatient services. But here's another point, and that is that when documenting services provided for the patients with more than, let's say, one diagnosis, there are a ranking of words or listens or to follow through. The ranking of the diagnosis must be done in a way as to represent the medical necessity. According to ICD-10, by the way, the guidelines, the primary or the most serious diagnosis should be coded first. It should go like this: the main reason for the visit, or the condition for the highest risk of morbidity or mortality that's being treated at the encounter, at the time. That's the way it has to be. The additional diagnoses, those that are describing other conditions that the patient has or should be listed in this case as the primary condition afterwards. Sometimes I get asked the question by many of our doctors. As you know, we have clinics all over the country. You can imagine the amount of questions we receive. What do I do? It says if the complaint is not on the approved diagnosis, the patient's complaint, the patient's chief complaint or complaint itself is not on the diagnosis, what do you do? Well, here's what you do. My response is very simple. First of all, reconsider whether the test is really indicated, if that is what you're doing. Next, tell the truth. Tell the truth. It is better for the clinic to absorb the cost of that procedure that isn't justified if you think you can't. Because someone forgot to put a rational diagnosis on the LCD, and because it was on the list, it's better to do that rather than having your family get to visit you once in a while because you are now in the federal penitentiary and you are incarcerated because of fraud. Don't you think that makes more sense? Absorb the cost and let it go? Absolutely. Don't take that chance. Here's a secret some healthcare providers referred that don't know. Most people don't pay attention to that. You don't need to say every single thing every single day in every note. You need to document daily why each patient is still in the status that he or she is in. That's true. And these patients are getting the treatment that they're getting. That's what it is. You know that. Copying, however, and pasting for you should never happen. It's considered an enemy to supporting any kind of medical necessity. It'll hurt you. It'll work against you. You may perform awesome medical decision making and an assessment plan, everything else on day one, but it's not as impressive when it is copied and pasted verbatim into day 4, 5, 7, 8. Not good. If you edit mindfully and justify your medical necessity today, you'll know that the change has been made and it'll be reflected in your content. Don't let the change from day to day or week to week be nominal. Here's something else that you need to consider. Avoid any kind of inconsistencies in your documentation. I see this so many times with the doctors. Or sometimes outright contradictions. That's even worse. If a patient is not stable yet, just say it. Stable says you are not this way, you are that way. Just say, stable, yes, but what? How? At what level? Until you remain improved for a significant amount of time, you are just stable. If you are not, then you are in a guarded condition. And in that circumstance, I recommend also avoiding language such as, the patient is without complaints, or the patient had an uneventful night. Really? Seriously? That's what you wrote on your chart? Why is the patient being treated then in your clinic at this point, if that's all they had? You should write instead, there is no significant improvement, or although improved, still with ... and everything else that you want to say. That's preferable. Focus on what is still preventing and transfer to a lower level of care if you need to. Otherwise, what are you actively managing on this patient? Think about these things. These things are so important. You want to get paid. You've rendered the service. You paid thousands and thousands of dollars to the marketers and developers and the staff and the taxes and everything else. And you're sending your claim and you're not getting paid and you don't have medical necessity to support. Ask why. Think about those things that I'm talking about. Here's something else. Knowing the coverage and the policies of the various payers can be very helpful. It can help you eliminate some of the claims that will be denied. The coverage policies of Medicare and the private payers, they typically specify the diagnosis codes that support the medical necessity for certain procedures, as well as the documentation requirements. If you're not proficient at coding and getting a lot of denials, There's a company called Medical Coding Outsourcing. Medical Coding Outsourcing. Check it out. It's a great way to ensure submission of a diagnosis codes that are supported by the medical record. Work with them. And there are many other companies. I'm just mentioning one of them. Just something to help you out. And with their in-depth knowledge, these companies about coding and guidelines and the payer rules and what have you, a skilled medical coder can help you as a doctor avoid claim denials and also educate you on submitting the proper documentation to support the services rendered. So, in conclusion, I want to make sure that you get this to walk away with. 2 things to remember. 1, when you see a patient for the documentation, tell the story like it is. That's it. Just tell the story. Speak the way you see it. Don't try to come up with words and things that just possibly would make sense. You're speaking to a human being who's going to read this. Explain it to them. And often that person may not even be a doctor. Second, tell the truth. Tell the truth. Because this is how medically necessary clinical protocols will be paid for. The care will meet the medical necessity for a reviewer, and they'll realize what you're saying. They'll see it. It'll come right through. And you'll sleep peacefully. You'll have a great day. And you'll know your staff, your patients, everyone will know that you speak the truth, because that's what you said. Don't make up stories. You'll get paid for what you've done. Because in life, we get what we deserve. Not what we want, what we deserve. And you'll get it, because you're a good doctor. As always, I wish all the best to you, and I look forward to hearing good news. Above and beyond. Let's make it happen, doctor, because you deserve it. And I wish you all the best. God bless you. Thank you. Please subscribe to my YouTube channel and click the notification bell to get my latest update.